think more such discussions need to take place and need to be organized, and I'm happy I found out about it and I could come.
Hello, good evening, and welcome everybody. It's my pleasure to kick off the event tonight. My name is Daniel R. I'm one of the founders of Guild, and on behalf of the organization and the team, we want to welcome you to a very specific, special event tonight in Cluj. And I think for a Friday night and for a very niche topic, I'm quite amazed how many we are here. I know it's the quality of the speakers that brings you here tonight. Before going on, I just want to mention our idea is to support the ecosystem in Romania by helping professionals get together, learn together in the guilds, which are not a new concept, but actually a quite old one. And we're very happy to have great professionals who meet regularly to learn together, to become better as doctors, as managers in IT, as entrepreneurs, as in different fields. And tonight we're very happy to see people interested in the management in the medical profession. And with that, I want to introduce my good friend, Marius Ungureanu, who is the brain behind this event. And I'm very happy that we have such great professionals as him. Actually, it's Dr. Ungureanu. I have to be precise here. So again, I know you came for him and for his guest, and that's why I want to welcome him, and let's give him and them a warm welcome, applause. So Marius, happy to have you here.
Thank you so much, Daniel. Thank you everyone for being here tonight. It's a great pleasure for all of us to be here. It's a great honor to have you here. I will not repeat what Daniel already said. For a Friday evening with plenty of choices of activities to do in Cluj-Napoca, we gathered here to discuss about how to fix our broken health systems, and I believe that we are the true hardcore change makers. And I'm really excited to see the ideas that will come out of this meeting today. Well, our meeting will last until roughly 9 o'clock, just to get your expectations right. I have my notebook with me because it's my great honor and pleasure to introduce my good colleague and friend, Luke, Dr. Luke Allen, and I needed to have my notebook because there are so many things that I have to tell about him, and it's not everything still. Luke is the co-director of Global Primary Care and Future Health Systems at the University of Oxford. He's been trained at, and this is maybe not the right order, at Oxford, at MIT, Massachusetts Institute of Technology, at Harvard, at the London School of Hygiene and Tropical Medicine. He is wildly productive. I get notifications on my LinkedIn every couple of days about some new paper, some new report that he's leading or contributing to. He has over 130 publications, if you were wondering what wildly productive means in my perspective. He is also an editorial member at a number of journals. I'll just name Lancet Primary Care and British Journal of General Practice. And last but not least, what I love about his work is that he has a passion for justice and equity. And for our health systems and for where our health systems are, where they should head to, I believe this is really essential. And before giving the word to Luke, I just want to quickly mention that we have this Mentimeter, and there will be a number of questions throughout our meeting. So if you are interested in answering the questions, and we would very much love for you to do that, you just need to go to menti.com and use that code 26273298. And then as we progress with the presentation, various questions will pop on. So with that, I invite Luke, and I really thank him for being here. He's here with his wife, Jo. Really appreciate that they took the time to travel to Cluj and to be with us. And Luke, you have the floor.
Thank you so much. That was a very, very generous introduction. And what a privilege to be here amongst the hardcore of Romania who are going to make a difference and reform the system. And I said facetiously that there weren't enough English GPs or a Gulean system because I am an English GP by training. So you could ignore that one, but it'll be interesting to see what else comes up during our time together tonight. So I was going to tell you a bit about me. Marius has just embarrassed me by making it sound really good. It's not all true, and if you are struggling to sleep or know a lot of insomnia, read some of my papers. They're all available online. But I primarily identify as a family doctor, so I see patients on a Monday in Oxford, people with bad backs and hemorrhoids. It's not very glamorous, but it's important. I'm a father. My wife Jo is here with me. She's a priest in the Church of England, and we've got 3 kids, roughly that big, that big, and that big. And beautifully, our youngest, who's 11, he's going through puberty, but still loves dinosaurs and trains and stuff. So that's lovely. The other 2 are very big. And yeah, I'm a health policies and systems researcher. That's been the main thrust of what I do academically. And it's about social justice. That's what exercises me. And in that role as well, I've been privileged enough to advise lots of governments around the world, and the World Health Organization, and the World Bank, which is something Marius does with Holsgord as well. We first met each other and on a mission in late lead. Come on, that was a pretty sweet mission. I mean, often you're just stuck in a basement somewhere, but that was a really nice one. Okay, so this talk this evening, I'm just going to go through 3 broad areas. So first, just to share my story and my career journey, because apparently that might be interesting. Probably not. You can just go on your phones if it's not, and share a little bit about the NHS and the challenges that we're having in the UK. Hopefully that will warm your hearts to hear that a high-income country with lots of investment in health still manages to catastrophically mess things up. And then I'm going to talk more broadly about the international health challenges that all health systems around the world are facing, externally and internally, before we come back to think our Romania, where you are the experts in the room. I'm going to be giving you just a couple of frameworks to help think about answering the question, how can I fix the health system? How do we think through that very tricky question? And then we'll see what we get up with that. We'll have lots of time for questions as well, so do write those down. But I just want to start, you've heard about me, to get a sense of who's in the room. So could you raise a hand for me if you live and work in Romania? Okay, raise a hand if you do not live and work in Romania. Okay, so. Also, okay, and if you work in the health system, it's interesting. Okay, so if you don't work in the health system, okay, you might need it next door for a different kit. You're the lead now. And if you're a clinician, you're good. If you're an academic, clinician, okay. What else? So some people over here. What are you guys doing? Masters in Public Health. Who thinks they are the least qualified to be sat in the audience here on a talk about health policy? Are there anyone? Dancers? Management? No. There are a few. My wife, Jo, deliberately knows nothing. Right? She puts her head in the sand every time I talk about health in any way. So that's really interesting. I think if I did this in the United Kingdom, it would be a U-shape, right? With people who they've got the cool aid, as we say. They're firm believers in the NHS, and no matter what the outcomes are, they think it's the best thing ever. And there are the realists and the cynics who think, actually, it's absolutely terrible. Maybe that's more, tells you more about British people than it does about our system. Maybe I've learned something anthropological about Romanian culture. Just here to see, or just stick in the middle, and I don't want to put my hand up and stand that. But so I promised you to tell you my story first. So I was born in the southeast of England, the bit closest to France, nearest to Europe. I'm the oldest of 4 boys. So bless my poor mother. My mum was a nurse before she had us, but then it stopped. Stay at home mum. My dad worked doing kind of finances for small businesses. So we were very firmly middle class. I had no idea what I wanted to do at school. I wanted to run around and be outside, really. So when it came to work experience, I spent some time with the army, running around the fields and poking things with sticks. But I didn't like being told what to do. I didn't really like the idea of killing people. So I quickly wrote off being a soldier as a career. I did well in my exams, unexpectedly. And my teacher said, well, there's law or medicine for you. I thought, all right, how uninspiring. And I remember being on the bus on the way home, and I had been given 2 books, How to Apply to Medical School, How to Apply to Law School. I thought, good grief, this is going to be my life. And I prayed about it. I said, God, I feel bad. I've got no idea. And I almost felt audibly the voice of God saying, medical school. I almost fell off the chair, but I thought, okay, wow, I'm going to listen to this. And then I applied. So I went to medical school in Bristol in the southwest, which is where all of the bums go. If you like surfing and aren't that interested in medicine, and had a great time as president in the Surfing Society. But I felt like a little bit of an outsider because all of my colleagues there have wanted to be doctors since they were this high. You know, they were, as toddlers, they were given little plastic stethoscopes and put plasters on their teddy bears. And I just didn't have that at all, so I had total imposter syndrome. And it's really hard medical school, as many of you will know. But as I got to spend more time seeing patients, you know, I really, really enjoyed the privilege of being let into people's lives. I was hearing about, you know, people going through really hard times. But still wasn't quite sure, you know. People always ask you, oh, what speciality do you want to do? And I was thinking, I don't know, I'm not sure. So I jumped at the opportunity to take a year out and do another degree. And again, I prayed about it and felt led to study something called international health. Not knowing anything really about it, I just thought, heck, it will slow down the time between me qualifying and having to do some real work. And on day one, the first lecture was on the value of soap, like something really, really boring. But if you want to save lives, you don't do operations, you get people to use soap and you can save millions and millions of lives around blood. I was absolutely hooked. I thought, oh my gosh, public health, that's where it's at. And public health also has this kind of social justice bent. It's often about working with marginalized groups, which really spoke to my heart and the work I was doing with hopeless populations. So I thought, brilliant, great, that's what I'll do, public health. So I went and finished medical school, but spent as much time as I could working with royal colleges of different specialities and did training in public health along the way. And then did my hospital training even further in the southwest, because the surfing's even better than that. And we had our 3 children on the money as well, didn't we? Jen and I met when we were 13. She's come along for the ride from very early on. And I was on a night shift in the middle of the night as one of the junior doctors in a hospital. And I was sat at a work desk and we had to choose what we did next. And I was thinking, do I really want to pull the trigger on public health training? And again, I'm a Christian and I was praying about this. And this is the other really big moment in my life where I felt God say, you should apply to Harvard School of Public Health. And I went, and fell off my chair. And that's how I thought, again, that was very odd, but I should take it seriously. So I went home, we did some research, and told Joe, who laughed at me and fell off her chair, because he got to do some quite hard exams to get in, including a maths exam, and my maths isn't great. So it truly was a miracle that I managed to get in. And I gave away all my medical equipment, thinking, this is it, I'll do this degree, I'll become Minister of Health, I'll fix the NHS, and that's it for me. If you get the chance to go and spend some time in Boston, it's a fantastic city. We had a great time. I mean, I don't have much weight to lose, but I lost a lot of weight just because your brain's going so fast. It's consuming bags of M&Ms by the day just to go. But the forces were great. It just really opened my eyes more and more to how health policy making works. Everything's political. It's all about who you know. It's not what you know. So it was Iron Man here, slightly nasty, but very kind of real quality ways. And spent spring break in Oxford doing a course because I'm a nerd. And I got some exposure to some WHO people and lined up a job at that. And the WHO Collaborating Centre back in Oxford. Spent some time in Geneva as well. So bless Joe. I mean, she really lost me as a husband for a year. Didn't really see what my children looked like between the ages of this big and this big. But I felt very much like I've been catapulted into quite a seedy position very quickly without knowing what I was doing. Which was great fun and terrifying at the same time. And good grief, God look after the people who I was responsible for. The good news is that most of the work at WHO, you write these reports, you spend months and months, and then they go in a drawer somewhere and no one ever looks at them. So the good news is there was kind of damage limitation built in. So I was spending more and more time looking at non-communicable diseases, particularly in lower middle income countries, the effects of poverty and socioeconomic status on our cars. And it became more and more apparent to me that countries that want to ban smoking have already done it. Right? There's kind of marginal gains to be made there. The countries that are more libertarian, that's not going to move anytime soon. And so why spend years and years in this organisation banging the same single drum? Most health is manifest at the community level. And it became more and more clear to me that actually primary care, so non-hospital based medicine, that's really where the difference is made. And about 90% of all health interactions in the world happen in primary care, although probably 90-ish% of the funding goes on hospitals. When you think of health, people think about going to the hospital. So it's quite a neglected area. And I'm acknowledging I really didn't understand it very well. I thought, gosh, I'm going to get trained as a GP if I want to understand how this part of the system works. So we moved to Oxford, did a vicar training there, and I went and trained as an academic GP. So it's like a specialty training program. It takes 4 years instead of 3. You're attached to the University of Oxford Department of Primary Care, and I had all these supervisors who did not know what to do with me, because the department does very biomedical research on diabetes, and I was into health systems. So they just kind of let me do what I wanted to do, which suited me to the ground. So I've told you from the army, I'm not very good at following instructions, so it was trying to have my independence. And basically, that's what I've been doing ever since. So a mix of primary care, I do about a day a week now, and I've had academic jobs as well, and I'm ferocious at writing papers. Doesn't necessarily mean they're good, because I can turn them out quickly. But also it's the policy stuff that I probably enjoy the most. So I've been a serial consultant for the WHO, and the last 5 years I've worked for the World Bank. And in both roles really as a health systems consultant, mainly around non-communicable diseases, health inequalities, and how do you design well-functioning health systems? As if I've got the answers. I mean, often like consulting is going in and asking questions because the knowledge is so often as it is here in the book. So that's a little bit about my story. If any of that's interesting to you, or you want to learn more about the bits on the way, that's what I'm here for towards the end, and we'll field some questions on those. Now let's move on to the next bit, which is another Menti question, which is, for those of you in health, why did you get into health? It probably wasn't the active voice of God on a bus. It could have been. I've talked about other me, social justice, job security. General practice gives me flexibility. Well, this is very encouraging. I'm not sure how much credence to give the fact that no one's making a difference to their bank accounts. So in the UK, I feel like most people go into medicine because of some bleeding heart, starry-eyed, I want to make a difference as a teenager. Then they get there and go, ooh, and lots of people leave. Hardly anyone goes in it to get rich, because, as the medics all know, there's lots of other avenues you can pursue, but you'll get much richer. And I was really shocked, actually, and as I spent time working with people in lower middle income countries, that actually money was the main motivating factor for probably a majority of the medics that I've met in job security. They're working in places where they're struggling to feed their kids. Medicine seen as a secure paycheck, and this kind of sense of vocation is often, much less frequently, the primary motivation. Okay, well, person's been told by. It's interesting. Anyone who's got other want to share? That's okay. That's okay. So, part 2, at the NHS. So, has anybody got any experience working in the NHS or being a patient in the English NHS? Tell me, Harry. I want to look at patient. It's a patient. I was going to say with what, but no, that's okay. Embarrassing rash to push over you. So the NHS, for the nerds, is a Shemashfo health system. That means it's centrally organised and it's funded by general taxation. So the other versions would be kind of social health insurance models, like France and Germany, the Netherlands, or a fee for service where you just pay for what you get, or USA, which is like the Wild West on steroids. Tend not to talk about the US, it's in the category of it. So, the NHS was set up in the 1940s by this amazing Welshman from the Valleys called Aneurin Bevan, who was really, really mission driven. And they were rebuilding the country after World War II and realized practically that we needed a healthy workforce. But his vision was really for a universal health service that the likes of which the world hadn't seen before, although the Soviets hadn't kind of been experimenting with that kind of thing. And the central promise of the NHS is that it's free to all at the point of use. So whatever your healthcare need is, you go to whichever bit of the system you need, you don't have to pay. And big idea, as with any health insurance system, is that everybody pays into it, and then money goes to those who need it, and hopefully there's enough money left in the system because not everybody needs it all the time. And rather wonderfully, at the time, the thinking amongst the Labour government was, we'll put loads of money into the system, because the health system will then treat all disease. and then the population will be healthy, and there'll be no more need for health. So this is like a one and done. Oh. So clearly that's not how health works, and actually the more supply you put into the population, it generates more demand. And over time, other factors happen, like your population ages, and the epidemiological transition from infectious diseases that you treat with some pills to non-communicable diseases like obesity and cancer and heart disease and strokes. You get these long-term conditions that require expensive treatment. So the costs, the amount of money spent on the NHS has just risen inexorably, which isn't unique to the UK, right? But we went in quite big with our kind of state-backed proportion of funding that we put in from the very beginning. Now today, the NHS budget accounts for over 40% of all government spending, which is absolutely amazing. And I know from the car ride with Marius that Romania's national spend is very much lower than that. But, you know, as a proportion of GDP, we're about 10%, whereas I think you guys are more around that. We're fine. We benefit because we don't have complex health insurance. It's a monopoly, so just one employer employs pretty much everyone who works. So we don't have lots of the bureaucracy that takes up, like it sucks up cash in Germany and other places, but we do other things quite badly. So our life expectancy is stalled and is actually declining. My kids could expect to have worse health than our generation for the first time, which again isn't unique to us. America is facing the same thing, but it was to be in a group with that. And there are these reports run by the Commonwealth Foundation, which rank theories of 7 or 8 countries. We used to come top, mainly driven by equity, but now our health outcomes are so bad that we're sinking down the ranking. Australia is currently sat at the top. The problem at the moment is that hospitals are driving massive deficits, and they operate on a fee-for-service model. So however many people come in will be treated, and they will suck up that money from the government to pay for the services delivered. Whereas primary care is paid by capitation, which means for every patient that we have, we're given some money. It's about 150 euros per person per year, and then you can bid for extra money on top. So to put that in context, the insurance for my dog costs more than I get given to care for a patient, like a human patient, per year. So it's not very much money. I quite like capitation because it provides a financial incentive for GPs to try and keep people healthy. So if I'm paid every time someone comes to see me, my incentive is to make them coming back, maybe to send them for unnecessary tests. If I'm trying to keep them out of the clinic, then I'm going to do all of my preventive work, try to make them stop smoking, make sure they're vaccinated. So I want them to be healthy out in the community. So I'm a big believer in capitation, but you do need safeguards because we could just lock the doors while surgery and say, sorry, we're not working today, and keep all the money and not delivering. So there is this fine tension between access and responsiveness. What that means at the national level, though, is that we know to the pound how much primary care is going to spend each year, and primary care never overspends, whereas hospitals massively overspend. And what's worse, when primary care gets busy, or there's a fall in the numbers of GPs, or there's a spike in an infectious disease, people don't want to wait more than a few days to see their GP, so they show up at the emergency department. And it costs £140 per consultation in the emergency department versus for all the care provided and money in. So as soon as the system gets out of kilter a little bit, you get this death spiral where people bypass primary care, go to secondary care, and costs just go through the roof at the moment. We've been in that death spiral for a very, very long time now, and every Christmas, every winter, the admissions go up, everything breaks, the wheels fall off, everyone pulls their hair out, there's an emergency injection of cash, which goes to hospitals again, not to public health or primary care, and the cycle repeats. So we've been in this difficult situation for a while. Some of the parties in opposition have asked about maybe adding an extra percentage to income tax to try and pay a bit more for the NHS. It wouldn't scratch the surface. And with the ageing population, the proportion national spend's only going in one direction, and no one is thinking particularly creatively about how we manage that. That is not a problem you need to target. It's worse in Japan, in South Korea, places with ageing populations. We've had how much of British news gets over here, that we had a big change in government this year. Basically every democracy in the world was voting this year. I know you guys are as well. Apologies for what you've been going through. And we saw the Conservative government leave after 14 years, so it was centre-right and increasingly corrupt and inept and arguably amoral. The bar is low for many politicians, but these guys really pushed it. And there was great hope for the incoming Labour government, who have been in opposition for a long time, have a thumping majority. And with that, are really trying to shake up and reform the NHS. And they've just abolished NHS England, which is a quango, so it's boring, so I can talk to you about that if you really want to know later. But fundamentally, I've not seen any structural changes which are going to address the challenges that we face. And what they've inherited is this massive deficit, spiralling costs, and currently 10% of our population is on a waiting list. That's 7 million people in the UK. And if I have an adult patient come into my clinic who thinks they might have ADHD, the wait list is 5 years currently. A child with autism, if they come to me when they're 10, they won't be seen until they're an adult, but which time I have to re-refer to the adult service. Things like dermatology takes about a year, gynecology takes about a year. It's really bad. And it's just been 14 years of underinvestment in capacity. As I've said, that's put pressure on GPs and family doctors. I was talking with Marius earlier as well. There's been a cultural shift. So the people in the generation above me got into medicine to make a difference. It's a vocation for them. And they worked all hours. They knew their patients need them. They loved their jobs. And they sacrificed their personal lives on the altar of their careers. My generation, the generation below, our social contract has slightly changed. I think if populations are more mobile, we move around, and patients move around, well, we lose that continuity and that connection to practice. But also just expectations about what's okay in the workplace is shifting. And people have the view amongst younger doctors is it's just a job for me. I show up, I get paid, and I go home. They're less willing to put in additional hours and go above and beyond to serve the patient in front of them. And there are good bits about that, and there are bad bits about that as well. But it's meant that lots of the older generation of GPs are leaving, and as conditions worsen, lots of the younger generation, whereas the older ones would have stuck it out, are saying, no thanks, I'm going to try consulting or finance or something else that will pay 5 times more, and I'll actually get to go every weekend. That's not helping. Again, there's another vicious spiral going on here. So of the 1.7 million appointments in the NHS every day, 1.5 million are in primary care. Since 2020, the number of appointments has gone up by 20%, but the workforce has dropped by a fifth, and a quarter of all practices have shut over that same period of time. So there's been an exodus of GPs either retiring or moving from working 4 or 5 days a week to 3 days a week. And I've gone from working 5 days a week to 1 day a week, so I acknowledge I'm hot in that ball. And demand is only continuing to go up. So it's up third with seeking care in the UK would be the my suggestion at the moment. So about 5 years ago, I think about 11% of people have private health insurance, but really that was either a work perk that was rarely used, or it was for the really affluent people, finance people in London. But none of our friends and colleagues have private health insurance. But increasingly, that market is growing. And that worries me, because I really believe in state-based provision. Everybody has a stake, everybody pays it. And I think we'll see this two-tier now, which is the case everywhere else in the world. But when the conditions in the private sector are so much better, it just exacerbates doctors leaving the public sector, moving into better paid, nicer jobs. And it just means that those who can't afford it get worse and worse care. And so I'm worried about that diverification, and I'm not entirely sure what to do about it. So answers at the end from you guys, but will be very well. Okay, so that's my bit on the NHS, which is pretty bleak, but hopefully reassuring if you're thinking Romania is terrible, which some of you put on that initial Mentimeter. You're not alone, and I think there are a ubiquitous set of issues here, and that's the next bit after I sip some of this water. Okay, so I think there's some external and internal challenges in health systems. And I've already given the game away. I've seen you nodding along, so I don't think I'm telling you anything you don't know here. But demography. The world is aging pretty quickly. More developed countries are aging faster than less developed countries. But the old age dependency ratio, that's the thing that we really need to keep our eye on, as the proportion of the population that's dependent on the workforce population. So countries like Nigeria are in a good place. China's just in quite a good place, where you get this kind of once in your history generational dividend, where you have this, normally you have your population pyramid's kind of like that, with loads and loads of kids, with a very high infant mortality rate. So not very many of them make it through to teenagehood. There's hardly any older people at the top of the pyramid. And then you start doing a better job of keeping people alive. And so you have a wide base, and then it kind of gets like that as people age. So you've got lots of younger people, lots of kids, and of course they're not really contributing to the economy, but they're relatively easy to look after, they're not that expensive. Few old people, and this growing bunch of adults in the middle. And then as conditions improve, the middle class, women stop having 5 babies and move towards 2 babies. The population pyramid comes in and narrows, and then you get this, it comes in really tight, you get this beautiful bulk where you get this entire big generation moving its way all the way up to ages. You'll get one point in time where you've got hardly any old people, very few young people, and a massive working age population, which is what India and China are going through at the moment. It's great. But then they continue aging, and people still aren't having children. You end up like Japan and South Korea and France and the UK and everything, which is lots of adults, very few kids, schools closing in the UK, schools closing in Japan, financial incentives to try and get people to move back into the villages because everyone's moving into the centres. And loads of old people. And old people are wonderful, but they're also often quite heavy users of the health system. They often have quite a few conditions going on that require expensive medications. And clearly they're not working and they've got pensions. And so the portion of the population that's working and paying into pension funds gets smaller and smaller and smaller. You end up with this inverted pyramid, and society collapses and we start eating each other. That's the concern, and my colleagues in Japan are very exercised about what they do with that situation. And that's not news, but it's a big problem for our systems. How on earth we manage to still provide a high level of quality care that's affordable for the population when tax takes are lower and the tax base is getting more and more narrow over time, without just resorting to a fee for service where if you're rich you can get your care, if you're poor, sorry, the quality of care really drops. So that's a really big kind of mega trend that everywhere in the world has to deal with. I touched on multimorbidity as well, so that this means more than one condition. Weirdly enough, 30, 40 years ago, it was really hard to find in medical school case studies where you'd have patients brought in with 2 or 3 different conditions. So I remember our professor really struggling to find someone who had diabetes and hypertension, high blood pressure. Whereas now it's hard to find someone who has one but not the other, right? And that's lots of things. That's the way our world has changed. That's the way lifestyles have changed. We're victims of our own success. Like, we don't have to move very much anymore. It's lovely. We're surrounded by high-calorie food. That's good in one way. It's not very good in other ways. And also things like the commercial determinants of health. So companies buying us with advertising the whole time, and pharmaceutical companies trying to kind of artificially lower the boundaries and the thresholds at which we diagnose people with things, prescribe people medications, ranging from opiate medications to anti-diabetics, people who aren't actually diabetic. Expensive technology. So another thing where we're victims of our own success. Medical science is amazing. People in this room are amazing. We're finding new discoveries all the time, finding new drugs, inventing new bits of kit. But that stuff tends to cost money. And if we want to keep people alive, there's often demand to use this new expensive, amazing kit to do so. And so that adds to the bill, the government. Migration is a massive mega trend as well. We're in an incredibly volatile time in history. Who knows what will happen in the next few years? But populations are increasingly mobile, and our health systems around most of the world are set up to deal with relatively static populations. We're not very good at managing large influxes of people. The last 3 are coherent inequalities. It's hard to tell if inequalities are increasing, staying the same, or going down, because it depends on the metric of the EU's, the country you're in, the reference points. But they're not going away anytime soon. And the inverse care law is still very much so. That's like a principle developed by, he was a Welsh GP called Julian Tudor Hart, said, the provision of healthcare services is inversely proportional to need, where market conditions are great. So pretty much everywhere in the world, the people who have the best access to the best care, the people who need it least, they're kind of young, fit, middle-aged, white men like me, and people who have the greatest need and are most underserved. COVID burnout is still raging, isn't it? I don't know if you saw the same impact on your health workforce that we did in the UK, but it was really bad, and it's been really bad everywhere. And the workforce didn't get as much support as maybe we'd like to have given them, and the mental health toll particularly, it's taken a lot of people out, and just beyond the health sector as well. And the number of young people in the UK who are on disability benefits because of stress and burnout is the highest it's ever been. And we're going to make up a number. I think it's something like 20,000 people across the UK. And the money's running out. So these are the kind of the mega trends which make it hard to be a Minister of Health or to run a hospital or to be a health policy wonk anywhere to go on, because these issues are breaking health systems everywhere, or tech even breaking. Internally, they're kind of outside non-health factors that anyone who reads newspaper knows about. Internally, what are we striving for in the type of care that we supply? What does high quality care look like? And where are things not quite going right at the methods? I just wanted to share with you the C's. So these are words to begin with the letter C that were created by a Canadian pediatrician called Barbara Starfield, who is a hero for anyone involved in primary care, who said primary care is really important. It can manage 90% of all problems in the local population. But for it to be good, it's got to have these characteristics. It's got to provide comprehensive care. So you've got to move away from fragmentation, where one clinician just deals with one problem, having teams that can deal with pretty much any problem in the population, excluding emergencies and stuff that really requires like a surgeon or some mental health hospital. You should be able to manage most stuff in your local population. Primary care should offer continuity. So when you see a clinician, you see the same person over time. Build up a relationship with that person. If that's not possible, use an electronic medical record so that when you see the next person, they've got a note of what happened to you before. If you've got to tell them, you all have had this experience where you go into a clinical setting, you have to tell your story repeatedly, and it's incredibly frustrating. You know it's written down somewhere. And from the clinical side, it's because you bear legal responsibility and the people before you might have got it wrong. But in the primary care setting, you're seeing people over their entire lifetime. And it is very helpful if you can get a medical record that is contemporary, it's up to date, and it pulls in what other providers from other parts of the health system have done as well. And health systems are bad at doing this all over the world, because individual clinics, individual hospitals and providers tend to have their own system, or they'll use a proprietary system that doesn't talk to other ones. And so they can probably see what their colleague in the same organization said to you last time they saw you, but not if you went out of hours, or if you went to the emergency compartment, or if you just had your hip taken out. And the excuses for why we don't have a fully interoperational system is it's expensive and complicated. But the value we leave on the table by not really pushing that agenda is criminal. So the only places that have done this really well are tiny, rich European countries. So bits of Belgium do it well. I imagine Estonia does this well. Estonia is really good at our stuff. And this is an agenda I'm trying to push a little bit more in the sub-Saharan African countries where I work, because they're not encumbered by these legacy IT systems where we've got to translate and speak to one another. Often they've just got paper records or no records at all. So you can build something from scratch. But for us in the UK, but you in Romania, your patients, they would be served if all clinicians could see what all previous clinicians had done. We should be pushing that agenda. It's largely not towards that. And again, there are powerful interests involved here. Coordination is the next thing. So primary care, ideally, should be a point, your family doctor should be the point of the system, and where even if they can't see what's happened before, every time they're referring you to see a specialist, that specialist writes back to them. So you get a letter, and your job as a primary care doctor is to collate that information, hold it in your head in some way, and then act as that patient's advocate and help them navigate their way around the system. Now that happens pretty much everywhere in Europe, because we're pretty strong at primary care, but around the world, lots of systems really don't have that. People trained to manage lots of different symptoms and undifferentiated illness, but are not a combination. And even in European countries as well, it does vary. That's another issue which we don't really talk about very much. It's very boring, but again, it's really important, particularly for patients who aren't well educated, know what they're doing, able to navigate complex systems. Again, health systems are tricky. They're really tricky to get around, and we need to make them easier for those who are the most minoritized in our societies. The last bit I've got here is community-centeredness. And the World Health Organization is really pushing primary care at the moment. And a big part of that is making sure that the health system responds to the needs of the person in front of you. And part of that story is about moving from the very paternalistic model, where people come and see the doctor, and in an Asian country as in recently, I got to sit to a clinic, and the doctor sees something like a patient every minute, so there's not a lot of time. Patient comes in and the doctor asks one question, and the question is, what is wrong with you? So the patient has to make the diagnosis, and then everyone gets given the same shot of it's a steroid, an antibiotic, and a painkiller. And they feel great, but it's not necessarily managing whatever the issue is there. There's lots of system things going on that we need to fix and to make that better. That's an extreme example, but even in practice that we will all have known, I bet we've all had experiences. I have probably been on the delivering end, where you go to see a clinician and they don't really ask you what's going on with the kind of a preconceived idea. And it's quite a one-way kind of adult to child interaction. And we want to move to a place where we're having adult interactions where patients and clinicians are working as partners, recognizing that patients know they're the expert in their own lives and their symptoms and what's going on. For some weird reason, medicine just throws that. Something like medical training makes you think that you're vastly superior in every way. Patients have no idea what they're talking about and need to kind of be told what actually they're experiencing. So there's this other transition kind of try and, I'm not saying about it, I'm sure everybody here is a very enlightened, excellent, high-quality clinician. So sadly, it's not the case everywhere. And that's still a big problem, trying to move away from the hammers. The other part of community-centeredness is trying to embed primary care within the level of unity, so that we're not just waiting clearly passively to come and see us. We're proactively thinking about what are the risk factors in this local community? What are the local social determinants of health? How does the transport infrastructure, the housing, the food environment, educational opportunities, pollution, how do these factors dictate the burden of disease that face on the population? And how can I increase my sense of agency as a primary care doctor to try and address them? We need to have time for the training and some financial incentives. And some parts of the world are experimenting with that, and we can talk about that at the end. But that's where I'd love to see primary care go, working hand in glove with public health, really managing the needs of the community, just individual patients in front. Okay, a little bit on international primary. The WHO is all about primary care at the moment. It's all about primary health care, and that's because we're getting towards 2030. And in 2030, we reach the end of this 15-year period where the world's got together to bang out some sustainable development goals. So this is the overarching health and development architecture that sets out lots and lots of goals and targets for governments to use to try and work towards things like increasing female education, eradicating poverty, eradicating hunger. And the main health goal is trying to achieve universal health coverage. That means that all people have access to the services they need without suffering financial hardship. And Romania does pretty good at that. Most of Europe does pretty good at that. The world's gone from about, it's scored out 100. The world's gone from about 33 out of 100, year 2000, to about 66, which isn't bad, except for the fact that most people live in countries with lower scores. So 4.5 billion people currently don't have access to essential health services. And you see that there are 14 tracer indicators that they use. It's things like people with high blood pressure are on a tablet for high blood pressure. People with diabetes are on a medicine for diabetes. Heat and vaccines. It's doing the basics mark. So that's been the framing goal. Unfortunately, progress has stalled since 2019, and everyone's really worrying about what we do about this. And it's really focused attention on we should probably be investing more in primary care, acknowledging that at country level, disproportionate amounts of funding goes into hospitals, when actually hospitals are vital and so important, but they're not actually delivering the basic essential services that are tied up with this measure of UHC. So that's like the overarching narrative. Allied to that is the idea of primary healthcare, which is annoyingly close to primary care and is used as a direct synonym. But primary healthcare came out of the Alma-Ata Declaration in 1978. It was a great big jamboree in Kazakhstan where world leaders got together and said, primary care is really great, we should do something about that. And then an awful lot really happened. But interest has been renewed. And it says, it's a vision for how we should manage health as a country. And it says primary care should be the central element. So lots of funding should go there. It should do lots of public health, and it should be integrated with the wider health system, which doesn't sound radical, but unfortunately it is. And there are two other main bits: multi-sectoral policy and action. We've got to be acting on the social determinants of health. Why? Because if you care about health, you probably wouldn't be in the health sector. Because hospitals and clinicians were only responsible for about 20% of all health outcomes. So any gains in life expectancy, we can claim credit for 20%. The other 80% come from wider social conditions, improvements in housing and sanitation, boring, important stuff that wider government does. So if you care about health, that's a big bit of it. That bit, health sector. The other part is community empowerment and engagement, trying to make sure that communities and people set the agenda for what health system does. All not clinicians or business should be working together, not just top-down way. So that's the kind of framing for where the world is going. And we've only got 5 years left, and then we'll work out what comes next. A paper that I'm working on at the moment is what comes next for primary care. So I've got no idea. So, man, you could be smart as that. Would be great. So I should be chat GBT me once. Okay. So coming into land two. How can we think about fixing these tectonic issues? We talked about the minutiae of how you want your primary care system to work, how you want it to relate with wider arts, and these mega trends which are screwing everybody together at the same time. A way that health policymakers tend to approach this is to break bits up into blocks. The most common approach is using the WHO health system building blocks. Has anybody heard of it? Raise a hand. Yes. Could be true, but I'm also pleased that most of you haven't, because they're quite basic. But, so there are 6 of them. Workforce. You lead a workforce. What are the problems with your workforce? Are they sufficiently trained? Do you have enough of them? Are they in the right bits of the system? And are they working together as they should? So general practice, our model is just train a load of GPs and let them get on with it. We want to be moving to multidisciplinary teams. GPs, family doctors are working with nurses, with healthcare assistants, with physiotherapists. And increasingly we think about task shifting. So does a GP need to prescribe every medication? Does a GP need to do every consultation for back pain or a snotty nose? Or could we train nurses up into those positions? Could we bring in pharmacists and get them to do more of medicine reconciliation work? So how do we use our workforce? That was block number 1. Block number 2, information systems. So I've already moaned about the electronic health record and how important it is that it's interoperable. But just having one is very important. And the IT infrastructure that the health system works on as well is another essential building. Again, Romania, you're not in a bad place. Considering the global average, most of your doctors use computers. Are you using handwritten notes in hospitals still? In primary care, are you using handwritten notes? Yeah, so there are problems because I can't read my writing. No one can read my writing.
You say no.
Yeah. I was working in a hospital when it transitioned from paper notes to computers. We don't like change, do we? We're a very conservative profession. You would have thought it was the end of days. People were crying in the corridors, and because it was a top-down reorganization, everything that could go wrong went wrong. You had these portable laptops on wheels, but the plug wasn't very long, so the battery would die instantly, so that you can't be out. Maybe if hack used Microsoft, so just as you had to do something important, it would update and block you out. Everyone lost their car. Everything that could go wrong went wrong. But come back a year later and suddenly, oh my gosh, I can read what Dr. Steinway wants me to do with this patient. So in terms of patient safety, really, as an N of 1, qualitatively, it made a huge difference. I haven't actually looked at papers and see if we ended up doing less medication errors, but I'm sure we did. So information systems is the second bit. The third is essential medicines. Again, sounds very boring. Romania does this well. But there is a list of medicines that the WHO says every facility should have, and it's basic stuff like aspirin for heart attacks, painkillers for people in pain. A surprisingly large number of facilities around the world, they have these essential medicines. There are lobby groups trying, the list is growing more and more at a time as pharmacy organizations and patient groups want to get their specific medication added to the list. And so there's an issue there about how much do we try and, what proportion of the government's limited resources should we spend on making sure that every clinic has these drugs available. The other interesting issue here is around climate change. So I've been working with some colleagues in South Africa where they had some flash flooding and all of their medicines were ruined because they were stored on the lower shelves. So they're having to store medication higher up to try to protect it from damage associated with climate change. Climate change also getting heralded of logistics and supplies and cold chains. And so whilst we might be able to afford essential medications, making sure that they're in the right place at the right time, available to use without harming people, is probably going to become a big problem. So the workforce, IT, medicines, financing is the next one. And yeah, you got to follow the money in most parts of life, haven't you? And I feel like a disproportionate number of people in health policy study financing because it's just so important. This is making sure that the government spends the right portion of all of its money on it. Making sure that within health, the money gets spent in the right place. It's thinking about how individuals get covered so that they don't have financial hardship. That's very important, and I think Romania probably could be spending a little bit more across the board on health. Then service delivery, once you've got those bits in place, how do you actually do the stuff? Do you have to meet guidelines in place? A patient who's got pain around their appendix, what's the pathway? Should they go to primary care first and then be referred, and then how do they get referred back? Those pathways through the system. The last bit is good governance. And everywhere has bad governance, doesn't it? It's much harder to count. Like, I can tell them definitively if I've got 15 or 16 medicines. It's harder, it's more qualitative to say if I've got good governance, yes or no. But really for me, this is about having values of equity baked into the constitution of the health system, baked into the policies. It's about having solidarity so that we look after every member of society, and every member of society is entitled to a basic good baskets of interventions. Let's start having accountability amongst leaders, so when they screw up, they can be kicked out and held to account. And with that, we're going to move to my final mentee, which is, of these big bits of the health system, where do you think the biggest problem is? You could select one option. I've been facetious with myself. But if you really don't know. Okay, so leadership and governance looks like it's going to stay at number one. What I'd like to do is to get together this time in a 3 or a 4. I'm going to give you a minute again. That is a huge category. So I'd like you just to talk amongst yourselves. What specific things is it about leadership and governance that is the problem in your setting? Okay, everybody, that's 2 minutes. So I'm really pleased to announce that we've solved the problems. All problems. We can go, well done. Pat yourself on the back. Okay, so I'm going to ask for some people to be brave. And you don't have to share what you said, but if maybe 1 or 2 groups, someone might want to share what the problem was they identified, and if they could get anything towards the solution.
There were many things that were very impressive and striking in what you said, but it was interesting to hear you saying what good governance means for you, because we generally say, okay, good governance, and possibly people think of many different things. In Romania, I would say that when we say good governance, that would mean efficiency. But you didn't mention that. What you meant with good governance had nothing to do with economics or economic ideas and entrepreneurship and so on and so forth, but you rather referred to solidarity. Good governance means solidarity, and good governance means tackling inequalities. So were we to meet the good fairy, we would ask her to help us build consensus around understanding good governance as struggling towards or doing something around solidarity.
Thank you so much. Can we have a clap for that? Yeah. Would anybody else like to go? That's okay. I'm not going to push you. I'm going to say what I heard here, though, which was, again, difficulty with power structures and payments and everybody having a price, and moving towards what would good look like or better look like was around having rigorous processes and accountability around decision making for those in governments. And there was one other bit to it as well, but I can't remember, but that's okay. Okay, so where I just want to finish is with just a couple of science pictures, if that's okay. And to introduce those of you who don't know about this concept before, stakeholder mapping, which is where we have an issue and we're going to keep going with governance isn't as good as it could be, and we think that's leaving value on the table in terms of economic efficiency, but also fairness and health outcomes. And some of the things that we want to do about it, like making sure that leaders in the health system have got clear processes, decision making, and there's transparency about what they're doing, and they're held to account if they act poorly. There are lots of stakeholders involved. We've heard there are leaders in the Ministry of Health, but there's also the government sitting above them. There are leaders in hospitals, there are pharmaceutical companies, there are patient groups, there are clinician groups. To Elon Musk, Putin, there's all sorts of people. You can put these actors in terms of the power they have over the thing we're interested in this case, reforming governance, and the amount of interest they have in the issue is a really helpful way of trying to move towards affecting change. Because we're very, very good at moaning about big problems. We're less good at getting distinct, solvable problems. We're a little bit worse at coming up with solutions that solve those exact problems. But then the last stage, which is even harder, is often the solutions we come up with are they need to change or that organization needs to change. But we've all been involved in making decisions in our families, in our workplaces, in other places. It's not an organization that makes a change, it's people. It's individual people. And sometimes it's one person, Donald Trump sending a tweet, often it's communities. The communities are made up. And so to really affect change, you need to know what the problem is, specifically, you know exactly what we need to do about it. And then who are the exact people who have the authority to make that change? And sometimes it's very simple. If I want to buy another surfboard, there's just one person I've got to convince if you sound like that. If I want a change in government or abortion legislation to change or end of life legislation to change, there's loads of actors in that space. End of life legislation is currently being debated in the UK. Lots of different groups, we're thinking about groups and organizations are interested, and they've got different levels of power. So I'm very interested, but as an individual, I'm about here, okay? The Catholic Church is very interested, and it's got, in the UK, roughly, it's around that line there. The Conservative Party, its power is dropped, but it's quite interested. There are some specific MPs and campaigners who are very interested in their powers, probably in that top quadrant. And there are different things that we need to do for people in each of the quadrants. So whatever your issue is, and you can use this for any issue, I would encourage you to think through who are the actors who are involved here, and then knock them on this space. And just go to the next slide. I'm just going to show you an example. The issue is launching puppies into the sun to the soundtrack of Blank Space or Taylor Swift. Donald Trump is very powerful, but he's not interested in this issue. Ursula von der Leyen she's against it, if you ask her, but she's not particularly invested in it, and her power to prevent it from happening is quite low. Elon Musk loves the idea, he has the means to do it. Taylor Swift is not a fan, and she's got a lot of power as well. She gives mobilize her supporters. My dog, again, is very much against it, but has very little power to influence whether or not this is going to happen. The four groups: high power, low interest. You need to keep these people satisfied. Okay? They're not going to kibosh. They're not going to ruin your plans as long as you don't give them any reasons. Just keep them where they are. The group which are low power or low interest, you can just monitor. I mean, effectively ignore. You want to see if they change. Most of the bond line could potentially go up in power and change your interest, but you don't need to much else. People down here, they care about the blocks, but they're not going to influence things, so you just need to keep them informed of developments. If you're leading a campaign, you'll let these people know, particularly if they're your allies, that needs to do anything else, and you engage really closely with people in the top line. So what can I do to make a difference for the issue of governance, reforming governance in Romania's health system? That is a huge issue. I'd encourage you to, whatever it is, try and break it down and say, what are the specific policies, the specific changes that need to be made? You've got to be like, who are the people who've got the authority to make that change? And who are the actors around them who are going to influence it? Where do they sit on this matrix? And now that's you focus on the ones close to the people in power. Try and work on those, particularly those who are neutral. Because they're the ones who can really make a change. People dead set, not work with people dead pro, they're really needy. The neutral people who are high interest, that's where I would see the loss. Now, I think we'll go into a bit more Q&A about what can I specifically do.
We're speaking about interest in the issue and then power, but what about, maybe shortly comment on, what about the situation when there's little awareness of the issue? Because in order to be interested in an issue, you need to be aware of the issue. And you did an excellent job in presenting the health systems building block. Maybe many of us had an intuitive knowledge of that, but we became aware of that structure, and I do that's essential. So can you provide any thoughts on that?
Yeah, so most people don't know what health policy is, including my mum, or care particularly until it affects them, or they don't know how it affects them. So I think the starting point for health policy is that people aren't aware, and they're quite happy not to be aware. That's okay, because that also means they're probably neutral. And you can be the first person to talk to them about an issue that you have an interest in. So if it's greater accountability in leadership, if it's about a change for health financing, if it's about reforming how health insurance works, most people they're not abreast at what's going on at the moment, and that's okay. If we're assuming that we start a group from the position where we want to change something, I think I would still do that mapping to work out who are the people who potentially do have lots of influence and power, but they're just not particularly engaged at the moment. And I would actively seek them out, make sure I was the first person to talk to them. Because then I can bring my framing up to the issue and explain why I think it's important before the baddies get to.
Thanks a lot. So I'll now get back to my initial list of questions. And the first one, it goes back to the health systems building blocks. And I also teach that to my students, but many times I have a difficult time explaining how these 6 building blocks are actually influencing the way our health systems work, because it's not just the individual building blocks, but it's also the way in which they influence each other. So health financing is really essential to having an adequately paid and motivated health workforce, and it influences health service delivery. So how do we address that, the complexity of our health systems, but starting from something which is fairly intuitive, and it would guide us in this process?
I love this question because it's very nerdy. And given that only 3 of you knew about the building blocks, potentially there's not much meat on this bone here, but the building blocks are a double-edged sword because, as you said, they're very intuitive. Yeah, I can see how you can bundle up issues with the health system in a way that's easily understandable. But they're very basic. They're a little bit like the first toy you get as a kid, those ABC books that you can stack. And that's not a bad thing, and they've got great global currency, and in WHO documents, despite the fact that they're oversimplistic, everyone gets them, so they keep being used. But when you start to try to describe how a health system operates, you quickly run into quandaries because they're just not sophisticated enough. And this is even true at the moment with the WHO climate change approach. WHO is doing fantastic work here. They basically present the blocks, there's 10 of them in their conceptualization, still anchored to those 6, but in like a donut, a round shape. And that's not really how the system works. A better way is what, again, the WHO has done with something called the primary healthcare monitoring framework and indicators, where they break them up into structures inputs, processes, outputs, outcomes, and impacts. The building blocks go at the left-hand side of that flow through the Hojiporo. But governance and financing actually come first, just as you said. And then come things like workforce and your IT as the inputs into the system. And the processes is around the service delivery bit there. Ideally, service delivery is about continuity, comprehensiveness, coordination, community centeredness, those magical C's. When all those things align, that's when you get the good outcomes. And at the moment, we're framing those into universal enough coverage. Everybody gets what they need without financial hardship. So they're pretty blocked, a bit like Lego maybe. They've just been presented in your hand, and I think what we need to do is put them into new order where it makes something a little bit more meaningful. Come and talk to me if you want me to show you lots of very boring frameworks at the end. I'll get very excited at my energy level. We'll get something and highlight it. I'll spare you anything more of that question.
Campaign that as well. One of the things that the frame of the 6 early blocks does not do a great job at is looking at the beneficiaries of the health services and looking at the health outcomes. And in Romania, the right to health is constitutional right. We have it stated in the Constitution. But despite that, we see that we perform fairly bad at some indicators. And it's not the average that is maybe the most important, but we're looking at how different levels of education or the different socioeconomic status impact the health outcomes. Recently, the European Commission launched the National Cancer Profiles, and we're looking at mortality rates, for instance, for breast cancer, and there's a huge gap between the more educated versus the less educated. And there are different factors at stake here, but I just wanted to ask you how or what international experience shows that we can do better at promoting fairness and equity, which are some of the values that you mentioned.
So the building blocks were first published in a report on one side of the diagram with some arrows pointing to the outcomes. And they, to be fair, but they did have equity and responsiveness and the health system there. So they're a part of an equation, but not the full part. The health for all, so the WHO mandate from the 1940s is based on the idea of health for all, which is kind of unarguably a nice thing to have. But when it comes down to it, what does that mean? Does it mean that everybody has perfect health? Because that's unattainable. Does it mean that you optimize everybody's health? But then what dictates a person's optimal health? Because if you're born into conditions of poverty, your maximum level is going to be lower than others. Do you aim for equality of outcomes, so everybody has the same level of health, even as that means that we pull down health for those who are currently healthier to lift up others? Or is it equality or equality of input? So you put the same amounts of money into the health system for every person. No health system has an answer, yet they all guarantee a right to health. So we live in a slightly meaningless void where we know that we want good health outcomes for everybody, but we're not quite sure how to solve that socially. And the problem is, where do you put resources? How do you allocate them between groups that have different starting positions? What do you do if someone decides to smoke and someone else doesn't decide to smoke? And you end up in this realm of kind of the deserving and undeserving core of these ideas that we get from the 19th century. So no, a pass. There's no international country that I think is doing a good job of saying this is my knowledge. It's really got the grips of what they mean by it's like it's an aspiration. And with the UN goals, universal health coverage, like it's a goal, it's a target, it's unachievable, but should we have concrete things that we could do tomorrow, or should we have these lofty ambitions we're never going to get to? We probably want stretching goals that we possibly could if everything went right, and then we'll be okay if we fall just short. That's probably where we want to be pitching these things.
Let me get to two of the hard ones. And I collapsed them. Initially, I had two separate questions, but let's just put them in one question. Politics and corruption. Surprisingly, I haven't seen anything about corruption on the first slide. When people were asked about, well, okay, there was one. My mistake, haven't seen. So, can we escape politics from health systems? Ideally, I would love to have that. And second, with corruption, I don't know to what extent that is an issue in the NHS. I don't know if I'd seen corruption. Was there any mention of corruption on first slide? Maybe not. That is still this surplus. Is there any particular advice, again, based on international experience that believe will work?
So I'll take the second bit first. And corruption is a ubiquitous problem, and I think it stems from human nature. So Immanuel Kant, philosopher, said, "Out of the crooked timber of humanity, no straight thing was ever made." And I think where you have people and where you have power, you have corruption, I think. As one said here, every person has their price, and I think if I was put in a position of enough power, I'm sure I would be just as bad as everybody else, I think. In the NHS, it's not a very big problem. No, because we've got structures and processes and transparency and accountability, and you get sent to prison, and there are high fines and there's reputational damage. And so we've, through pain and effort, created a system where corruption isn't there. Or in the balance that people make, actually, you're less likely to benefit if you take a crime. The way to get rid of corruption, and I would say to Marius, I'm not an expert in corruption and health systems at all, and there are lots of people out there, and quite a mature literature. So if this is something you're interested in, really serious political scientists and scholars have engaged with this. But from my limited knowledge and experience, the countries which have gone from situations where things have been really bad to making quite fast progress has been with quite radical agendas led by people at the very top of government, but they've made a series of very high-profile arrests, particularly of people who would be deemed by society to be untouchable. The institution of very high fines and jail terms, which are consistently implemented, sending a very clear message that crime doesn't pay. But you also need conditions in the system to be good enough that work pays. And I think, from what I gather, the situation has got better since public sector pay went up in the health sector a decade or so ago. And I think more of the same is probably needed there. So you need good paying conditions, and to make it like a less rewarding option to take a bribe. But that's very hard to do. And it takes someone in a position of very high power with access to resources. You know, these people are heroes, and we should have a lot of time and respect for people who are pushing those agendas. The first part of your question was, can we and should we divorce politics from health? And the question is, no, we shouldn't, and we can't. We shouldn't because we can't. Health is intrinsically political, because it's about power, every single bit. It's an interaction between people. There's an information asymmetry. We've got the ability to save people's lives and to make them better and improve quality of life. There's the money in the health system. And we've got to make really important ethical decisions about where money goes and what our priorities are. So do we disproportionately channel money to working age population at the expense of old people? And is everybody get access to the same level of care, even if it's not necessarily the best level of care? Should we aim to have more CT scanners per head, or hospital beds per head, or primary care doctors per head? And these decisions massively impact the population's life. So the population should have a say in it, and the way that should have a say in it through a democratic process. So we can't and we shouldn't remove it. Having said that, Sir Keir Starmer, the head of the Labour government, has just shut down NHS England. Well, actually, that was because there was a reform by the predecessor, Andrew Lansley, previous health secretary, who thought politics was too involved in the health sector. And health is a political football because it's so political. There are all these ideological arguments all the time. And they felt that it was making it very difficult for the health sector just to get on and do its job delivering care, because the goalposts kept getting changed by politicians. So they introduced NHS England as an arm's length body to be run by technocrats, so that the government would set the overall which under the then boffins, clever people would decide how health is run day to day. But with this huge mandate, the government's keen to bring it back closer under direct political control, so that, because they're feeling like they're pulling these levers and actually nothing's changing. So they want to bring it a little bit closer. And you see as how ideologies change over time in different countries, the relationship between where power sits with Democrats and the political levers changes. Of course, the other axis is the centre and local, so devolution as well. Kenya has just seen a massive power being devolved from the centre to these county governments. It's fascinating, all these experiments around the world.
Excellent. And I have two more questions. They'll be quick ones because I don't want to be too selfish. I want to allow our participants to ask them their questions. But the first one is, if we're looking at the title, so the title of today's event was, How Do I Fix My Broken Health System? And we've seen a lot in various ways in which our health systems are broken. And then you did an excellent job in showing us various ways in which they can be fixed. But I would read again the title and focus on how do I fix my broken health system? And so maybe something that would be some advice for our participants today. We are a diverse group here. Some of us are pensioners, some of us don't have anything to do with the health system, but are impacted by the health system. So what are your thoughts on what should each one of us, each I in the room?
Yeah, I think there are three things that I'd encourage you to take away. First one is politics. So for most of the things we care about, it's a politician who's going to be in that high influence, high interest group. And they're the ones that have a big say about where resources go and what happens. And this is a democracy. This is still a democracy. And you have elected, accountable leaders, more than other countries. I can see lots of people going there. But you will have members of parliament whose job it is to represent you and your views. And, okay, your voice might not matter as much as you hoped it would, but public support and opinion does matter, still has currency to people. Even in dictatorships, dictators worry about what their population thinks. They worry about popular support. So write to your MP, or whatever your local equivalent is, and go and see them and use social media to tag them in things, to bug them, and make yourself known to them and then use it. So exercise your democratic rights and at elections, vote for the party that aligns with what you think should be happening. So number one, be politically engaged. Number two is community organization. So you can directly speak to politicians. Often they don't listen, or your voice counts much less than the big funder or the donor or the company. So you need to get support. And so I encourage you to find like-minded people and think about doing a stakeholder mapping process and trying to bring on board more powerful groups that share the same passion and interest as you. You can leverage a little bit more influence, say, those decision makers. The final bit is being the difference yourself. And if we're talking about leadership, okay, fine, we need to make sure that we're allocating resources efficiently. If lots of the problem is basically we need people of integrity who are going to stand up for what's right and not take bribes and give voice to people who are currently being sidelined. We all have the opportunity to do that in our everyday lives. As clinicians, as academics, as quality researchers. But where our gaze is, where we spend our time, where we spend our resources, and how we act as patients in the system and as providers in the system. So I just encourage you to go home and reflect on the values that you'd like to see in the system and how you can play a role in living those out in your life, which that's really, really tough. But it's really, really meaningful. And for me, that's the outworking of my faith as a Christian. It's that daily reality of trying to be, but we are more for that too. That's really important to this TikTok.
Excellent, Luke. And my final question is that little trick of the title, and it is, how do we change our broken health system? Let's say that we are a group. We already found out many things about each other tonight, so we can say that we are a group. What would be your advice to us here? How do we change ours?
Well, it was just great. It was great that it was so hard to stop you talking. And there's clearly a lot of experience and knowledge, passion and healthy rage in the room here. And I think there are people like you, find people like you that share the same passion. You've got to give this space like this. But trying to move from general doom scrolling towards being quite clinical about, as a group, what are going to be the 1, 2, 3 issues that we define us as a collective that we're going to try and push on, and trying to get specific. And then using tools like the one, there are many tools, like just the one I showed, to work out who this group is, what this issue is that we want to change. That would be my encouragement to you. And it looks like you've already got the means to make a difference, you know. Revolution starts with a room full of people like this.
Thanks a lot, Luke. I really love this healthy rage. I do agree. There is quite a lot of healthy rage in true. Thanks so much, Luke. And now we're moving to the third part of the meeting, and this is where we are taking questions from you. I don't know if you can use menti.com, but I can also go through the room, and if you have questions, just raise your hand and or yes, there's sure.
An observation and a question. We all in the Northern Hemisphere, we complain a lot, but we have at least systems to criticize. And I think, I'm speaking as a political scientist and economist. So you mentioned Kenya. So I've been last year to Kenya, and they don't have a demographic problem. They have not an aging population. They have the working age force is like 30 million, but only 3.1 million people have a paycheck. And that includes cleaners to high-paid jobs. So it's like, with the economy like that, there's no system there's no system, actually. And the question would be like, what do you mean by fixing a system where we know a lot of goals are aspirational? And where would you draw the line, and you would say like, this is broken and this is not broken? Because you mentioned a lot of things like financial sustainability, demographics. Is it there can be a brokenness because of like structural issues, like there's not enough people to pay to sustain the things cost, and there's like structural issues which are not like given, but are like corruption, misalignment, bad policy. So where would you draw a line? Or would you say, okay, this is, but it always needs improving, but fixing, and where would you say this is broken?
Thanks. So there are a couple of ways of tackling that question. The first is to say that the title is trite and catchy as opposed to being nuanced, and this is a nuanced issue, Matt. The second is to say that we talk about systems, but they're really complex beasts, aren't they? And we've talked about these blocks. I think the first part to do is break up into the blocks and then say, is this block working well? Or if the system as a whole isn't working well, how can we diagnose what's going wrong? And I'm a big proponent of system dynamics and causal loop diagrams. There's ways of trying to put on paper messy systems with feedback loops and lots of those. One way stepping back would be at the whole thing and saying, is this system working, yes or no, a binary way. We rarely do that. I think the UK population feels the NHS is broken. So I think often there are those tipping points where like there becomes this societal agreement that something's not working fundamentally well. And in the health policy sphere, we tend to use three main criteria for, is the health system doing its job? One is responsiveness. Is it responding to the needs of the population? So the services is delivering matching the health needs of people and meeting their demands for a level of healthcare. The second is it delivering acceptable clinical outcomes? So the fact that life expectancy is falling in the United Kingdom, we're not doing very well in that one. Again, there's not a hard and fast measure there, but clinical outcomes is the second bucket. Third is it financially sustainable? The money we're putting in, are we getting good outcomes? It's that kind of economic efficiency. So there are the three kind of temperature gauges we look at when we're trying to make a global assessment about our system. If any one of those is off, that's where you kind of lift up the hood and try and work out which system's not working properly. And often it's lots of bits. And then for each bit, what does working properly mean? Again, it's, these are huge fields of inquiry where it's definitely not a yes, no. But at the end of you end up with a kind of, something's not right here. So that's why we talk about it. Something called the AAA. So those three things that they're responsive to your population, not letting them die. You can prevent it, being financially sustainable and having good outcomes. They're three that you're supposed to hold together. You can't just be like, oh, we'll just do well. But you're right, it's ideology, right? This isn't objective truth and everyone should do it. This is the current perceived wisdom. And there are proponents, for instance, in COVID, talking about system corrections, there want people to say, oh, we'll just otherwise people die and then it will be a good health system because the most vulnerable, expensive people are dropping off. You hear some of the arguments around smokers. No, it's good that they smoke because they'll die younger and they're down to bed much. But it's not a view I subscribe to. And then just to touch briefly on your other thing about what about systems that don't have a system? Systems can be badly organized or very fragmented in when it comes to things, but pretty much every country on earth now has some kind of insurance or offer that the government provides. So I work with the Libyan government, I work with both governments in Yemen. In the most challenging places on earth, there's still, there's some doctors in Gaza at the moment, there's still stuff going on. Is it a coordinated system? No. And just to touch on Kenya, Ruto, the current president, really came in wanting to bring reform. And you're right, the tax base is tiny because the informal economy is so small. And so he's a central plank of his presidency has been trying to widen the tax base, trying to widen the insurance system so that more people are covered under the state system at the moment, which actually operates pretty well, given GNI, gross national income. So there's hope in all these spaces, and actually, I'm working in Botswana on electronic health records, and as I said before, they're not encumbered with the legacy IT systems that we had. They're able to kind of leapfrog and lead with amazing innovations that we just can't do because we've got all these contracts with all these companies. So they can go straight to an interoperable health record if they wanted to, just like we've seen in parts of sub-Saharan Africa with internet banking, massively overtaking what we've been doing in Western Europe. So it is more challenging without resource, but there are opportunities there.
Execute IPWS questions. Here, do you, as the general practitioner and have not done the theory, can we see the other? I see that there are two.
We're not going to answer this one whilst it's up. There's a debate in the moment raging in the British Medical Journal and the British Journal of General Practice. They both see themselves as international in scope rather than just UK focus, saying that GPs are wasting far too much of their time on the preventiveness. And actually the guidelines in the US and the UK on what we should be doing for each patient in terms of advising them on smoking, checking their cholesterol, etc., would take 27 hours per day per patient to do. So clearly it's ridiculous in terms of the volume of preventive work we're expected to do. We can't deliver it all. Where does the balance lie? I think we should be doing tons of preventive care. I think we should be working closely with public health. I think we should have protected time. I think we should be paid to have financial incentives to do this work. Otherwise, we'll just default to the very reactive, passive model where sick people come and see us. We never try to get beyond it to keep people happy and repeat.
Maybe there's one niche stick to that, so key to the this one. What are troubles at initial cases with trying these preventive care like water use issues?
So hospitals are a problem in that hospitals are great and we need them, but the funding model at the moment is that they routinely run up huge deficits and suck up all for spare money in the system. The previous government reduced the amount of funding that went to public health significantly over the course of 40 years. And to change the situation, we can't free up more money unless government spends more of tiny. We just don't have very much tax incentive at the moment. The British economy is not in a great place, so we'll either have to reduce even further the amount of money spent in other parts of the economy to spend more on health, or we've got to readjust things within health. And it's much easier to readjust things in health than it is to further squeeze the budgets of education and transport and sports and culture. But at the moment, with hospitals running up billions of pounds of deficits every year, it's really hard. I don't know whether, is there an easy fix? Not really. So when the new government came in, they said we're going to release an extra tens of millions of pounds, but it's a drop in the issue. So it does need more money. I think the mindset of most GPs in the UK and lots of clinicians is we're trained to deal with the inhibition in front of us, which is great. But we're less minded to think about a population from which they've had. And I only got the social determinants of health when I studied public health. And I was like, oh my gosh, why isn't this like normal? And then we've got to learn it the other way around. So the answer for everything always comes down to training, and training is not very effective, which should be structural. But there is something about the mindset of doctors. Because there isn't currently the demand as well coming from our profession to be doing more.
Thanks a lot. That will take two. I want to take one question. This one from here, and then we have two in the room, and then we'll end with one from here, and then we're still in time. So, is there a chance that European Union could have a unitary system for which Japan contributes to the same impact, and states can transfer the technology much more easily?
No, it's just replicated.
One question there.
Yes, I have another. The second question for the anterior one was, do you know a health system that already makes a great job increasing the preventive care? Is there any health system?
Yes, Slovakia has been very deliberate about investing in public health prevention and does a very good job in integrating public health teams with primary care teams. And they're very good at data sharing as well. So the local public health team is directly linked with data with primary care, and they're able to develop health profiles for the local community and then feed that back to people on the ground. And community-oriented primary care is a model of care. It's a way of running a system that was set up in South Africa in a community called Floridia, and it was cut short by apartheid, unfortunately. But some of those guys influenced what's happening in Ghent, which is in Belgium, under an amazing clinic and set of clinics run by a guy who's retired called Jan de Meesener. And again, that's a primary care clinic, but they employ dentists and physiotherapists and a big multidisciplinary team, as well as forms of social workers whose job is to analyze social data from the local community to work out what the local drivers of disease are, and then work with other stakeholders in the community and the council to try and tackle those social determinants of health. And so when we went to visit Ghent, Jan took me outside, and the first thing he wanted to show me wasn't the clinic, it was a road intersection, because they'd found that there were injuries and deaths happening at this very busy intersection nearby to the clinic. And so they engaged some architects and city planners, and they went to the council, redesigned the road, and the injuries have stopped. And that's the thing he was made to pound off, not was delivering antibiotics to people with pneumonia. That's a fantastic one.
My question is probably more personal because of my profession. I'm a psychiatrist, and we had a small discussion about the key ingredient that it's needed for governance and leadership, and we mentioned integrity. And then another small discussion, what is integrity in your opinion? And you mentioned something about your faith being connected with integrity. If you can explain more about this.
Nice easy question from the psychiatrist, thank you. Just lie down, pick it up my shoulder a little bit. And I don't have a pithy definition of integrity, gosh. Something I think I feel here more than I understand up here. And a mentor once explained it to me as, if you chop me in half, I'm the same all the way through. Something about not being two-faced, and what I say is what I mean. If I commit to doing something, I'll follow through. And you can trust my word. So something about trustworthiness, being honest and frank, and not being the same with everybody. But my faith, so that's come up a bit, and it's very important to me, and it's probably the reason why I told it's the reason with like Voice from God was slightly narrowing it down. But Joe and I met when we were teenagers. It was through our Christian faith that we came to see in the life of Jesus that our passion was really in social justice, trying to make a difference. We were the classic white saviors. Let's move to Africa and save the world. And that's where we started off. We've been on a journey since then, right? And it's been over the years as being a Christian work and seeing the teaching in the life of Jesus that being honest is a core value. In the kingdom of God, there are these core values, to love people, you've got to be kind to people, you've got to forgive people who wrong you, you've got to be honest in your dealings. And so, that of course you can do all of those. You don't need to be a Christian. The Muslim unique is to be a wonderful person and exhibit those values. They're not unique to Christianity, but for me, I think it's the driving force has been my faith in seeing that in the life of the example of Jesus as like, that's what I want. I want to be more in you. And so in the workplace, in a home where I'm with kids maybe, it's trying every day to exhibit those values. The integrity part at work, how does that manifest? Trying to treat all of my patients equally. So in Oxford, where I am, I get lots of psychiatrists and important doctors and professors and innovators. But we're on the edge of the city, so we also look after a very big estate. So we get drug addicts and alcoholics, so people who've beaten up their partners, and it's trying to make sure I'm delivering the same level of care, with the same level of compassion for everyone. It's important. And think that as well about trying to be humble and not overstate my station. And I get to meet really interesting and amazing people like Marius and you guys all in the world. And trying to do the same with you as I know with kids. That's it. Another city example that many other comes out. Marius language.
Thanks a lot, Luke, for sharing that with us. And final question for tonight. If our health system would have a mind, body, and soul, which part do you think does more dictate, and how would you approach its holistic treatment?
Okay, well, from what I've gathered from the root, my sense is that the body is okay, that there are immune system. I think you've got the pieces. If we think about the building, like you've got arms and legs and doctors and clinics and some money in the system, maybe not a map. Is it the mind or the soul that's the problem? I mean, my impression from you is that there are bad actors in positions of power that are abusing the responsibility that they've been entrusted with. And for me, that's about ethics. And so I think it's so. Right? Well, how are they trying to treat it? Yeah, and I think the three of them, I'm a big believer in holistic treatment. We have the biopsychosocial model where we try not as GPs, we don't just treat the knee, we think about the person in the wider context. Well, that's much I'm not going to teach you about primary care. But I don't think you should just treat one thing, they're all connected. And so I think the mind for me is about that accurate diagnosis. Who are the people? And it's not just they're corrupt, what's the specific thing that's wrong? We talked about accountability, transparency, due processes, and having the right kind of penalties in place for being consistently enforced, at being very sharp about what needs to be done to get to a place. And then I think the body needs to be involved in moving in that direction, right? So clinicians, the workforce, and patients are going to need to drive for it. It's very rarely that ill gets sorted itself out. I think it's going to take a collective effort. This is torturing a metaphor here, isn't it? But I think all of you are going to have to be involved in moving forwards to treatment. But I defer you to my daily colleague here. It was too much for insightful and papers and drinks with you.
Thank you so much, Luke, for everything. I just want to, for all of us to